Hi, my name is Kate, and together with my Lego crew, I'm delighted to present the findings from my HRB-funded PhD today. I have to acknowledge the researcher's bias first. I have type 1 diabetes and I'm on an insulin pump. I was diagnosed in 1987 and I had to take injections, sometimes even 10 a day, so I probably shot millions of them already. And I just got rid of them. And yeah, that's me when I was 7. So I got an insulin pump, a small device that delivers insulin continuously, and then when I wanted to eat something, instead of an injection, I just had to click a few buttons. It gives more flexibility, improves the quality of life, makes diabetes management more effective, reduces diabetes complications, and it's not only me, there's plenty of systematic reviews and other evidence highlighting it. However, it requires good diabetes education and multidisciplinary approach, ability to carb count, the willingness to be attached to a device, and money, of course. In Poland, I had to pay out of pocket every month at least €100 for infusion sets and every 4 years, £4,000 for the device itself. So when I moved to Ireland and I learned that it's all covered by the long-term illness scheme, I thought, whoa! But in terms of accessing technology, I learned it was a very, very different story. And this is where this mixed methods research begins. First, with my supervisors, we had to assess the prevalence of type 1 diabetes. There's no diabetes registry, so we analyzed the prescription database. Only then we were able to estimate the uptake of pumps across the country. We found that only 7% of adults were using pumps in 2016. And just to mention, in the UK it was 15, in Germany 35, and in the USA, even 58% of adults. The uptake varied fivefold between the counties, from 2% in Clare or Kerry to almost 10% in Kildare, Wicklow and other Dublin areas. The uptake was centralized and clearly associated with the availability of insulin pump therapy in diabetes clinics. Our national survey showed that 1/3 of clinics was not offering any type of insulin pump therapy services at all. Some clinics only provided the follow-up care, and less than a half provided training and education to commence insulin pumps necessary to start the treatment. And even in those specialized clinics, only 13% of patients were on pumps in 2018. After 4 focus groups with people with diabetes from the areas of low, average and high uptake of pumps, and 21 interviews with healthcare professionals and key stakeholders, we found that the determinants of access and uptake of pumps are the capacity of the clinic, mainly resources and expertise, structure of the health services at the local, national level, awareness of technology and its benefits, and impact of an individual. As one of the participants said, HCP and their attitude towards it as gatekeepers is absolutely huge. They are a key barrier or facilitator. Data synthesis showed us other determinants. So if you live in the right place, you get the best care. If you live in the wrong place, you get screwed. So what? This study highlights that there is inequality in accessing the best quality of diabetes care in Ireland, and access to medicines and treatments is much more complex than just dependent on reimbursement. The greater the awareness, the more chances for change. So thank you very much for listening, and thanks to the HRB for this opportunity. Bye!